present autonomic dysfunction be present in, they are not present in myopathy. Most consistent and classical pattern is usually in most of the cases there would not be a problem. More symmetrical and proximal involvement with power would any sensory or autonomic dysfunction in my, although vice versa would be present in. Okay, Ji. These are some kinds of dystrophy which we usually come across. The most commonest among this is Duchenne muscular dystrophy. The second one is Becker muscular dystrophy. There may be myotonic muscular dystrophy, which is usually present in later stages of the life, and then limb girdle muscular dystrophy and facioscapulohumeral dystrophy, and last but not the least, congenital muscular dystrophies. Regarding Duchenne, it is the most commonest type of the muscular dystrophy, which has the most incidence on all these, and it is a kind of X-linked recessive disease. I hope until now you people must have an idea about the diseases which are transmitted via X-linked pattern or X-linked dominant and autosomal recessive and autosomal dominant. X-linked recessive uh, is the disease of pattern is a pattern of the disease in this current scenario. Clinical features can be divided into gross motor muscular portion. In gross motor, when the patient is presented to you in infant age group, they are usually rarely symptomatic. In this part, they are able to roll over and they are able to sit and stand at appropriate ages. Poor head control may be the first sign of weakness. Then it may be and may not be present. The first and classical sign which we usually encounter in clinical setting is Gover's sign, which is usually evident after 2 years and 95% cases it's usually evident uh, perfectly at 3 years of age and fully expressed by 5 to 6 years of age. So we have to pick it early to diagnose it early. Toddlers may have symptoms like waggling gait, delayed walking, frequent falling, toe walking, difficulty in running and walking upstairs. And then if disease is manifested in full blown case and patients would be confined to wheelchair, but 10 to 12 is the in most cases, and can also be a part in their immobility. This is the classical Gover sign, which is also known as on himself. And starting from the upward, you can appreciate in this the child cannot lift up his body without taking assistance from the surroundings. That he or she would be in most of the cases he, as it is a pattern of X recessive. So he would be taking assistance from the floor or from the any chair or from any other thing in which from which he can take any kind of assistance. So climbing upon himself is the word used for Gover sign कि वो आहिस्ता आहिस्ता करके अपने posture को uplift करेगा and finally he would be able in to stand in somewhat erect posture. सबसे पहले वो अपने फ्लोर से अपने आप को असिस्ट करेगा और उठाएगा, देन टुवर्ड्स नीज वो अपनी नीज पे हेल्प लेगा एंड देन अगेन वो अपनी बॉडी के ऊपर से ही हेल्प लेते 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 असिस्टेंट लेते लेते फाइनली एक सो कॉल्ड इरेक्ट पोस्चर में अपना पोस्चर मेंटेन आएगा. इट डिपेंड्स ऑन द सेवेरिटी ऑफ द डिजीज दैट व्हाट काइंड ऑफ अ पोस्चर अ चाइल्ड इज एबल टू मेंटेन. He may be able to maintain a fully normal posture and in most of the cases not so well developed or ideal posture. Regarding the muscular part of the disease, muscular weakness usually progress into the second decade. There may be complaints like myalgias or muscle spasm, but usually they do not occur. And then the involvement of pharyngeal muscles and respiratory muscles. If the respiratory muscles are involved, then there may be weak, ineffective cough and frequently pulmonary infection. And if there is involvement of the pharyngeal muscles, then there may be symptoms like aspiration, nasal voices, and nasal regurgitation of liquids. Again, as I earlier said, that in myopathy part, the distal movements and the distal part of the muscles are usually preserved. So these kind of patients are able to perform functions with spoons, with pencils, and they can use the keyboard and the things which involve mainly the distal border parts, that is the finger part of your body. These are usually preserved, and if the patient is not severely involved and not falling into the severe category, he would be able to use his distal portion of the limbs precisely than the proximal portion. And then there may be contractures often involving ankles, knees, hips, and elbows. Again, ankles, knees, hips, and elbows are the more proximal parts of your limbs, and extraocular muscles remain well preserved. So these are some differences which you come across in the clinical scenarios. Whenever this scenario is given and you have some kind of ambiguity or confusion, so I have just made it somewhat bold just to memorize those important points. So there would be a proximal muscle weakness, usually more evident after 2 years of life, and the patient may present or complain with not walking properly, tiptoe walking, and climbing upon himself, that he cannot use toilet and things like that. And when you take the history or in the scenario, it can be given that the distal portion, like combing, like buttoning, like using pencils, are more precisely the patient would be able to do than the proximal part. Anal and urethral sphincter muscles is uncommon and occurs very late. So these are the muscular part of the disease. And a classical feature in Duchenne muscular dystrophy is pseudo-hypertrophy of the muscles. As I described earlier, muscles portion are there, and it has almost normal girth. These are not atrophied muscles, rather they seem to be hypertrophied muscles, but they are not fully functional in their proximal group. So enlargement of the calves and wasting of the thigh muscles are classical features. In coming slide, I would be able to describe it in more detail with pictorial form. Enlargement occurs due to hypertrophy of the muscle fibers and infiltration of the muscles by fat and collagen proliferation. So, why these muscles get hypertrophied? There are mainly two reasons. That is infiltration of the muscles by fat and collagen proliferation. Whenever these unused or not so properly used or not so properly formed muscles are there, they get infiltrated by the fat, and a large number of collagen proliferation is there, resulting in hypertrophy of that specific group of muscles. Specifically in Duchenne muscular dystrophy, these are enlargement of the calf muscles. After calf muscles, mostly the side which can be involved is the tongue muscles, followed by the forearms. So it can come in clinical scenario, it can come in the MCQs, that if the scenario is given and you people can be asked by what are the other sides which can be involved after the calf muscles. So these are the two other main sides, that is the tongue and the forearms. Tongue fasciculation do not occur. Again, another major differentiation, tongue fasciculations do not occur. Remember the word do not, as tongue fasciculations are usually the part and parcel of congenital myopathies. So whenever you encounter with something like tongue fasciculation, do not consider Duchenne muscular in your differential diagnosis. Last but not the least, the clinical part, deep tendon reflexes. As I have been discussing in my whole presentation about the differences between the proximal and the distal groups. So knee jerk is less brisk than the ankle jerk and lost after 6 years of age. Similarly, ankle jerk remains well preserved till terminal stages. So the proximal, the knee joint, the proximal the joint is, the more is the chance to get involved. As simple is the rule. Similarly, brachioradialis reflex usually stronger than the biceps. So the proximal joint would be involved uh, more frequently and apparently affected more as compared to the distal joint. So in upper limbs, brachioradialis reflex usually strong than the biceps, and in low limbs, ankle jerk remains well preserved till terminal stages as compared to the biceps and knee reflex. This is the pictorial diagram which summarizes all the symptoms, starting from the head and back. Shoulders and arms are held backward when walking. These all are the clinical picture in a child. You can see, or you will be able to appreciate. There will be swaying of back and belly sticks out. And what would be the reason? Because of the weakness of the belly muscles. And there would be thin, weak thighs and hypertrophy of the calf muscles. The thigh muscles would be weak and thin, and the calf muscles would be hypertrophic. And there would be tightening of the Achilles tendon, and weak muscles in front of the leg may result in foot drop and weak butt muscles. So to summarize it, there would be somewhat protuberance or prominence of the belly because of weak belly muscles, and there may be weakness of the butt muscles, and there may be weakness of the muscles from front of the leg, that is thigh muscles, but hypertrophy of the calf muscles, tightening of the Achilles tendon, and foot drop because of the weak muscles in front. So this is the pictorial and clinical presentation which you appreciate clinically whenever a child with classical signs and symptoms of Duchenne muscular dystrophy comes to you. Okay, moving on towards the investigation part or the diagnostic part. What would be the investigation we would like to carry out? The first and the foremost important investigation is creatinine kinase, that is CK levels, and it would be in thousands. Normal, the value is 160 international unit per liter, and when the results come out, it usually above 15,000, in the range of 15 to 35,000. So whenever you come across with CK that much high, always think of muscular dystrophy, specifically Duchenne muscular dystrophy. And other supportive investigation, that is aldolase and AST, they might be raised. EMG and NCS तो बिल्कुल नॉर्मल होती है, ई में मायोपैथिक आपको मिल सकता है. And as I discussed in my presentation, your respiratory muscles, so chest X-ray, echo, ECG can be done to determine the cardiac and the lung functions. And we can also go for the PCR for dystrophin gene, that would be positive in 70%. Last but not the least, muscle biopsy. That is the diagnostic. So if one test which is the diagnostic, that would be muscle biopsy. And the first test you would like to order is creatinine kinase. So at least you must be able to remember these two investigations specifically for Duchenne muscular dystrophy, that is CK and muscle biopsy. Biopsy is not done in all of the cases. For example, if there is a family history of the current illness and patient is having classical signs and symptoms with raised CK, so that is the enough criteria to diagnose the patient with Duchenne muscular. So we would not advise muscle biopsy in all cases. What would be the findings in muscle biopsy? They may be atrophic and hypertrophic muscle fibers seen, and increased connective tissue, as I discussed. The muscles are invaded by the fat, and there will be increased proliferation of the collagen. So increased connective tissue between muscle fibers, and both hypertrophic or atrophic picture can be seen. Depends on the stage of the disease. How would you diagnose the carrier of the disease, as all of the children or family members cannot be informed symptoms? So other family members, specifically the male members, treated with creatine kinase that would be raised in 80 to 90% of the cases, and the remaining 10 ambiguous carriers, or which are not clinically fitting into the criteria, but still you are suspecting a case of a Duchenne muscular dystrophy, so you would go for muscle biopsy, and PCR would be definitive in that cases. So coming to the last portion of the topic, that the treatment of the Duchenne muscular dystrophy. I hope till now you all are able to understand the Duchenne muscular dystrophy. If any queries, you can ask at the end. Treatment is no specific cure available. First thing, and respiratory infections are and the involvement of the heart are the two important complications which we usually encountered, and the most lethal complication which we usually encounter is cardiomyopathy, and we have to refer the patient towards cardio people to manage with that. And if that happens, then we have to treat the patient promptly. Digoxin can be given in a patient if it is cardiac decompression. And the supportive thing which we can do, the nutritionist part, that is, we have to add calcium and fluoride supplementation. Avoid the obesity, and it would increase the burden. It would increase the burden of the disease to the patient, and avoid excessive vitamins. All we need is calcium, vitamin D, calcium fluoride. Physiotherapy contributes little to muscle strengthening, but it has some role. Excessive exercises accelerate the muscle fiber. So you would not advise excessive exercise to the patient, and contractures may be useful in functional rehabilitation. Another thing which sorry, yeah. नहीं नहीं, कैल्शियम, विटामिन डी एंड फ्लोराइड सप्लीमेंटेशन देनी है, एंड ज्यादा एक्सेसिव विटामिन्स को अवॉइड करना है. ओके जी. Last part of the treatment is the steroids recommended during ambulatory stage of the disease. Strength improves initially, but steroids cause in most of the cases osteoporosis and obesity. What kind of steroid we can be given? It has a specific way to be given. First days of every month, and then avoid chronic complications. Not going into the details that how we can prescribe the prednisolone and deflazacort, and dexamethasone or triamcinolone are usually avoided because they induce myopathy, as they are fluorinated steroid. So all you have to remember is there is a role of steroids, but a limited role, and in some cases, and what we can give is prednisolone and deflazacort. And regarding recent advances, that is antisense oligonucleotide drugs can also be given. Just to add the flavor, I have just added the name of the recent advances, that is antisense oligonucleotide. You people must be aware of recent advances and recent things are happening in the particular disease and the particular scenario you are dealing with. So you must be aware of that. It can be a part of your question as well. Okay, what are the recent advances in Duchenne muscular dystrophy? So these are the antisense oligonucleotide drugs. So that is all about the Duchenne muscular dystrophy. If anyone wants to ask any question or any query, you can ask.